We are back here talking with the docs on our 8:30 high beam, and welcome, Dr. McKnight. Dr. Jakubowski.
Good morning.
We had advertised, I guess, had some common lower extremity problems. So we're going to start at the waist and work with our hips and knees and ankles and whatever you guys want to do. So.
We talked last night, like, what are some of the common things you're seeing in the office? And Dr. J talked, and I mentioned some things I was saying. I thought, well, this is common. These are some common issues. So we'll just start with a hip. When somebody comes in the office with hip pain, especially if they're older, the first thing I'm thinking is, oh no, their hips wearing out. Are they going to need hip replacement, or are we going that route?
Yeah.
But when you ask them where the pain is, a lot of times they'll point to the side of their hip, almost where the thigh bone attaches into the hip socket. And when they point there and I touch that, that's usually a bursitis of the hip. There's a sac around all the joints, and sometimes those sacs get inflamed. And there's also a muscle or a tendon called the iliotibial band that attaches in that same area. And so, if we push on that on the side of the hip and it's tender, that's a hip bursitis, and that's a pretty easy fix most of the time. I will give them an injection. It doesn't go into the joint. It goes basically close to the bone, just underneath the skin, and then I'll send him to Dr. J, and he will work out the tightness in that area. So this happens a lot from people that sit too much, primarily, but it's also can be mechanical. People are walking a little bit with a hitch. Maybe they've got one leg a little bit longer than the other,
which is common.
It's common most of the time. Dr. Jakubowski can kind of work that out, even the hip, even the legs up, because it's more of a muscle tightness, one area that pulls the leg up a little bit. Sometimes it's anatomical. You got one bone a little bit longer, but often it's a mechanical issue that he can help with. So I'll let Dr. J talk about some of the things he does with hip bursitis, and sometimes he'll also be able to assess that, this probably is a joint. It's a different type of pain. I'm going to let him kind of describe that because he sees that pretty often.
So you're working on the bursa sac, and he's working on the muscles and tendons.
Yes.
So like he said, when we see hip issues, a lot of times, if it's not arthritic, it could be mechanical in nature. So we start to see bursitis develop, because those are usually repetitive strains on muscles that alter mechanics, and then your body's trying to take pressure off of it, and for so long it can deal with it, but then other problems, inflammation builds. So bursitis is a huge part of that. And then what we do see is muscle tightness associated with bursitis, but a lot of times why that muscle tightness shows up, and like Dr. McKnight said, it's because people sit a lot now, we're at computers and things, is because muscles become weak. Certain muscles become weak, so these other muscles that aren't part of that whole group to protect the joint have to take over. They become tight, and it's really this weak muscle. So when we sit a lot, we sit on our glutes all day long. And what we know about the glute muscle, it's a huge protector of the lower back, and it protects the hips. So when we sit on them all day and we don't use them, that's what happens. Those muscles become weak, and the deep gluteal muscles have to tighten up to help take over some of the job of that bigger muscle, and then we see these altered mechanics. Also, of course, we can see arthritis show up in the hip, which is a very common thing as we start to see older people develop this stuff. And I find in office, one of the main things I see that I know it's maybe an arthritic issue compared to just a muscle mechanical issue is when people have groin pain in the front. When they have groin pain and they try to bring their leg across their body from them, so if they bent their knee up and bring it across their belly to the other side, they'll have groin pain associated with that. And when we see that, we start to question, okay, how much arthritis do they have in the hip? And how much is this a muscle issue that we can fix, or do we have to send them elsewhere to have maybe look at closer to the hip and how worn out it is?
Anytime we say itis, we're talking about inflammation of some sort, right?
Yes.
Right. Yeah, so, that's, we go back to the preventive things. And like you said, we sit too much, and we don't use those glute muscles. And our hip flexors get tight because they're at a 90-degree angle between our body and our thigh as we're sitting in a chair. And so we really have to stretch that hip flexor, and we have to strengthen the gluteal muscles. A great exercise for that is a lunge. But people have to work at this, and they have to do this carefully so they're not straining something that they shouldn't strain. They need to have good posture. They need to be supervised. Usually physical therapy can help them with that. But once they start therapy, they're just showing you how to do it. You have to continue to do it. If you're going to continue to sit, you got to continue to do these exercises, or you'll just be right back with the same problem.
And I would say with stretching, if you're trying to do it fast, just forget it.
Well,
do it slowly so you don't injure something else.
Yeah, sure. And it's got to be a commitment. And, I was talking to a teenager the other day who's a dancer, and she dances 4 or 5 hours a day. And I said, can you do the splits? She said, yes. It's taken me a while, but, almost any of us with some commitment are capable of getting to that point. And people would shake their heads and say, no way. Well, it's because you don't begin to do that. It may take months, it may take a year or two to get there, but the body will respond to the things you tell it to do. So that's a real common hip problem that we see. The other day I saw somebody come in with complaining of knee pain, and his leg was cramping. I thought, boy, these are two separate issues. Well, as I examined him, the pain was not it was not so much in the joint. It was a little bit in the front under the kneecap, so there might be some arthritis there. We'll get an x-ray. But he had a lot of pain behind the knee. And he had a little bulge in that knee, and I wondered if there was a little cyst. We call it a Baker's cyst or a popliteal cyst, where you get some swelling, some knee fluid back there, and it makes it painful to bend your knee. But he also was having cramps in his calf, and I think his knee pain was caused by calf tightness. So I got an x-ray, and I said, I want you to just go see Dr. Jakubowski, because I've had that problem recently. And, Dr. J always smiles when he puts you in pain during a procedure, but he's smiling partly because he knows I'm going to feel better, and he knows his patients are going to feel better. So what he does with active release therapy is just amazing, and not too many people do this. So this patient is going to get an x-ray, make sure there's not arthritis at the knee joint or behind the kneecap, and then he's going to go see Dr. Jakubowski, who will be able to use his active release therapy and his other treatments to help him with the pain, because a lot of people are really tight behind the knee.
Active release.
Yeah, so what Dr. McKnight's talking about is basically when we see some of these issues where the muscle's tight, it's repetitive injury that can develop, and altered mechanics that causes muscles to become tighter. However, when we overuse a muscle too, kind of like when we exercise, we use the muscle, we tear down the muscle fibers, and we rebuild it so it's stronger. When we have a chronic issue where we're continuously tearing down the muscle fibers, continuously to tear, we have altered mechanics, and then scar tissue forms. So a good way to release scar tissue, because basically what scar tissue does is stops blood supply to the muscle, and then it makes the muscle very tense and tight. So basically in active release, what we do, our goal is to put the joints through their range of motion while we put pressures on the scar tissue to tear the scar tissue down. If we tear the scar tissue down, we can restore mechanics. We get blood supply back to the muscle tissue and to the joints, and then people feel better from it. However, like Dr. McKnight said, when we use active release on extremity joints, it can be uncomfortable because we're stretching a very tight muscle. Kind of like if people have tight hamstrings, they go to stretch their hamstring muscle. Like, man, this hurts so bad. Mm-hmm. But the more you do it, the more you stretch, the looser it becomes, and then mechanics return, and then people feel better.
Well, it's not going to get better if the scar tissue stays there.
Right. And the best way to do that is exercise, therapy like active release, physical therapy to correct those mechanics, then continue an exercise program. Because let's be honest, a lot of us sit all day, go to work, come home, sit, watch TV, eat dinner. We're not doing the things that kind of improve or stimulate all our muscle groups to make that better. So if you do have the therapy, and that's what I tell people all the time, you got to get active, because we can make it feel better and it'll do well for a while. But if you do the same thing day in and day out, sit, and it's just going to recreate that altered mechanic again. You're going to rebuild the scar tissue, and then you're going to have problems again. And then you're like, boy, I got to have this treated again. This is just not fixing. And then it's that chronic cycle.
It doesn't have a brain. You have to use your own.
Yeah, you have to take responsibility for your health care.
Yeah, there's sort of a tissue threshold that you can put microtrauma to the tissue for so long before it breaks down. Then there's a breaking point, and as the individual, you're thinking, I didn't do anything, and all of a sudden my knee hurts. Well, you've been sitting, or you've been maybe in a plane all day long, and that lowers that threshold because you're sitting with your knee bent. And then you do one little thing. Maybe you say, I'm going to go at the gym, and I'm going to do some leg curls. And you haven't done those in a couple of years. And the next day, you're sore, your knee's sore, and you're thinking, well, I shouldn't have done those leg curls. But then a week, 2 weeks later, you're still hurting. And that trauma that you caused with that one exercise in tissue that was already beginning to become weak and tight is all you need. And it doesn't go away unless you do the things Dr. Jakubowski's talking about. So people, they want the quick fix, take some ibuprofen or some pain medicine, but we're trying to restore normal mechanics. We have to understand that's why we work so well as a partnership, because we both appreciate that. And when I was having my knee problems recently, it was a lot of running, a lot of basketball, and then it was leg curls and some other things I was doing in the gym in addition to that. And I was waking up at night with knee pain. And at first I thought, oh man, I hope I haven't torn a meniscus, because I didn't remember the injury. But it bothered me at first, and then once I got talking to him, I'm like, I'm going to be okay, because he's going to cause me pain, and it's going to feel better. But it's the point I'm trying to make is this tissue tolerance. You break it down little by little, and eventually one more activity just sets you over the edge. It happens with the shoulder, with bursitis, happens with the knee and the hip, and all these things we're talking about. So it's a commitment to staying flexible, proper mechanics, and just think, if I'm sitting all day, I have to create the opposite posture for my limbs and my knees and my hips that what I'm creating all day. Otherwise, you're going to continue to be tight.
Yeah.
And I think what Dr. McKnight's saying is also inflammation is a big issue, right? So when we have the altered mechanics, it creates more inflammation. But we also notice, and I think it's easier to notice too in diet, if we're eating bad foods too, inflammatory foods. We kind of notice that first in our knees or ankles or things like that, where they can be the most sore, and people maybe go to that McDonald's line, garble down that Big Mac fry and Filet-O-Fish, and then the next day they're like, man, my knees hurt more, or it's hard to get out of bed in the morning. So I think the keys is watching for all that, eating properly. There's supplements you can take for extremity aches and pains, like glucosamine and those type of things. Those things seem to work very well in practice. We notice that people that take that have less of those issues. So if we target some of that stuff, people do well.
So eating the fast food standing up really doesn't counterbalance that.
You have to do while you walk 5 miles.
Yeah. But I think that makes another point that I want to tie in with COVID, because COVID, the people that do poorly with COVID typically have underlying inflammation before they come down with it.
Okay.
And when the body sees that virus and says, boy, we're overwhelmed, let's try to take care of it, there's an inflammatory response. If you're already inflamed because of your diet or because of maybe excess weight or other health conditions, now on day 7 to 10 after you become symptomatic, we call that the cytokine storm stage, when the inflammation just really peaks. And some people, their inflammation response is already geared up, and now they geared up further, and now it's fluid in the lungs and the breathing problems, and those are the people that really struggle. So we're coming back to the things that we've been talking about for years here. Keep the inflammatory load down, get rid of the gut. Don't eat foods that are processed or high in sugar that cause a lot of inflammation. And then with Dr. Jakubowski, it's always about restoring proper mechanics. You have to pay a price for that, and you have to go to the right places: physical therapy, chiropractic, a physician that can help you, direct you to those places and understand how all those modalities work together. I think it's really key, and that we're just trying to emphasize the importance of correcting our body in any way we can to its natural state.
We want to feel young. So that's
what we want to
do it. Gentlemen, thanks so much.
Thank you.
It's always good to have both of you in here.